Okay, everyone, welcome to ISGyP Live Journal Club for November 2020. The theme this month is GYN cytopathology. I'm your moderator, Natalie Benet. And just as a quick plug, ISGyP Live is offering events on a monthly basis. I just wanted to highlight two recent events, and one recent and one upcoming. Dr. Talia spoke with the podcast about pathologic features of atypical endosalpingiosis. That went live on the 11th of November. You can actually follow the link at isgyp.ca to hear that. It's on a SoundCloud account. And then our upcoming webinar on December 3rd, featuring Dr. Blake Jilks on updates on vulvar squamous cell carcinoma and its precursors. So you can also register for that at isgyp.ca. So our objectives today are to engage trainees in gaining scientific knowledge and ability to critically evaluate the literature, to offer opportunities for trainees and young members from all parts of the globe to volunteer as presenters and moderators, to provide membership, and to engage the future leaders of our field from around the globe. So this month's theme, I didn't update the top, sorry about that, but it's GYN cytopathology, and our three articles are listed here, and we will go in this order, and our presenters are three trainees. First, Dr. Valarie McMurtry. She is a PGY4 at the University of Utah School of Medicine and has future plans to do molecular and cytopathology fellowships. So this is a very topical month for her. And Dr. Swati Bhardwaj, who is a veteran of GYN ISGyP Journal Club. She is a PGY1 at the Icahn School of Medicine at Mount Sinai and had previously trained in her home country of India. And then Dr. Priscilla Njenga, who is a first-time presenter and a resident at Icahn University in Nairobi, and is actually a trainee of one of my former trainees. So it's nice to have people from all over and all levels of training. And our schedule today will be a brief intro by me, and then each of our presentations should take about 15 minutes, 12 minutes for the presenters to discuss their presentation, and then we'll have a polling question with participation from the audience. And then at the end, we can have discussion and questions as needed. And just to quickly review the webinar format for Zoom, the Q&A function is how we will submit questions. So that's in the black bar at the bottom of your screen, highlighted with that blue arrow. If you see a question that someone else has submitted and you like it, you can hit the thumbs up arrow, which is that second blue arrow down at the bottom. You can hit that little icon and it will prioritize those questions, and I'll know that that's something a lot of people would like to answer. The chat function is also at the bottom. You can use that to leave feedback, but if you leave your questions there, I may not be able to monitor both spaces, just as an FYI. So that's all for now, and we can go ahead and have Dr. McMurtry, you can share your screen and we can get started on your presentation.
About the first paper, which is the endocervical glandular involvement is associated with increased detection rate of high-grade squamous intraepithelial lesions on the Papanicolaou test. So, as some background for this study, endocervical glandular involvement, or EGI, by high-grade squamous intraepithelial lesions, or HSIL, is associated with higher rates of residual or recurrent dysplasia, and this is independent of margin status. It's commonly diagnosed in surgical specimens. However, it's not required by the Bethesda system on Pap test specimens. However, this study came out of Johns Hopkins, and they say that they diagnose EGI by HSIL on these Pap test specimens. And so the basis for this study and the question they sought to answer was, can EGI be identified and diagnosed reliably on Pap test specimens? So first, let's go over the differential for hyperchromatic groups on Pap test specimens. And so this does include HSIL EGI, and it's EGI on histologic specimens is identified by high-grade cells with high NC ratios and hyperchromatic nuclei extending into the endocervical crypts. However, on Pap test specimens, the criteria for the diagnosis have not been definitively determined. And so this is kind of the differential for what to expect with hyperchromatic groups. It can be atrophy, benign endometrial cells, adenocarcinoma in situ, which has kind of this feathering look, as well as hyperchromatic groups, endometrial cancer, HSIL alone, or HSIL EGI. So the methods for this study, in their case selection, PAPS has specimens with the diagnosis of HSIL EGI with follow-up specimens within a year were identified, as well as the reverse of this. So they looked at surgical specimens with a diagnosis of HSIL EGI with a preceding PAP within the prior year. They also did the same process for HSIL alone to serve as a control group. They also looked at inter-observer variability of HSIL EGI diagnosis on PAP test specimens. They used 20 PAP test specimens, 10 of which were diagnosed as HSIL alone, 10 of which were HSIL with EGI, and they were reviewed by 6 observers, 2 of which were board-certified cytopathology attendings, 2 cytopathology fellows, and then 2 cytotechnologists. First, we'll look at the correlation between the PAP test specimen diagnosis and the surgical specimens. So when we compare the histologic diagnosis of HSIL versus HSIL EGI and what their previous cytology looked at, like we see that the diagnosis of HSIL on the surgical specimen was more likely to be preceded by a diagnosis of LSIL, while a SurgPath diagnosis of HSIL EGI was more likely to be preceded by a higher grade diagnosis such as ASK-H, HSIL, or carcinoma. However, we see that HSIL EGI was not associated with the surgical follow-up of HSIL EGI. In table 2, we look at the comparison of the cytology diagnosis and what the follow-up histologic diagnosis was. And so we see that a diagnosis of HSIL on the preceding PAP was more likely to be followed by an HSIL diagnosis, while HSIL EGI on the preceding PAP was more likely to be followed by a surgical diagnosis of HSIL EGI as well as adenocarcinoma. Another finding of their study was that EGI was more likely to be diagnosed on larger specimens. When divided by sample type, larger specimens such as cones, leaps, and hysterectomies were significantly more likely to reveal endocervical glandular involvement than more superficial specimens such as biopsies and curettage, regardless of the preceding PAP. And so we see here that even with a preceding PAP of HSIL alone, the percentage of HSIL EGI was much higher on larger specimens, and the same with the preceding PAP of HSIL EGI diagnosis. Next, they looked at inter-observer variability. So overall, the inter-observer concordance for this study was poor for identifying HSIL EGI on PAP test specimens with a kappa of 0.23 or poor agreement. There was significant variation in the threshold for diagnosis of HSIL EGI by the observers, with a range of an observer diagnosing HSIL EGI 25% of the time to 70% of the time. There were 4 instances in which the observers were 100% concordant. In 2 of these instances, the cytologic diagnosis was discordant with the surgical diagnosis. And so here, when we dive into the data for this, we can see that the top 2 rows are where we had 100% inter-observer concordance, but discordance with the cyto and surgical specimens. The bottom 2 rows show the 100%, the other 2 cases, and we can see that those were HSIL alone all the way across. So when divided by the top 4 photos show PAP test specimens with high inter-observer agreement and a diagnosis of HSIL EGI on cytology and surgical specimens. These specimens contained loosely cohesive, elongated cells with hyperchromatic nuclei, and in some instances, these cells project away from the tissue group. In the bottom 4, this is that top specimen in the top row where all of the observers diagnosed HSIL EGI, but the surgical diagnosis was only HSIL. And we see that in these representative photos, we see several of the images are very similar to the ones that had agreement on HSIL EGI. Of note, the observers were only instructed to choose between the diagnosis of HSIL alone or HSIL EGI. So in their discussion, the authors touch on 3 main points. First, their result of HSIL EGI diagnosis on Pap test specimen has poor sensitivity and a high false negative rate. And they postulate that this could be due to a combination of factors. Individuals may not screen for EGI in Pap test specimens. Maybe EGI is not well sampled by the Papanicolaou test, or HSIL EGI may not appear significantly different than HSIL on Pap test specimens. The next result that they discussed was HSIL EGI on Pap test specimens was correlated with higher HSIL rates on surgical specimens. This could be because EGI is correlated with multicentricity and positive margins, and EGI is also known to occur in patients with larger disease burden, and thus maybe we are more likely to sample HSIL on these Pap test specimens. The result that positive predictive values of EGI diagnosed on Pap test specimens varied significantly by follow-up surgical specimen type. This could be because EGI is a relatively common phenomenon and supports the intuitive rationale that the presence and extent of EGI is more easily appreciated on larger and deeper surgical specimens. The strengths for this paper include that this is a difficult topic to tackle. This includes the largest sample size to date and the first to really test inter-observer variability. This might lead to more pathologists reporting EGI on Pap test specimens, leading us to have more robust data to look at. The areas for improvement: this is a retrospective study, and some pathologists may have not reported EGI or felt comfortable diagnosing EGI on the Pap test specimens since it is not required. They could have used education to improve the kappa of their inter-observer agreement. However, this points to the elephant in the room that no consensus on criteria for diagnosing EGI was identified. They even reviewed specimens with high concordance and still couldn't define criteria. So this might be institution or even pathologist specific for the diagnosis. This study did not include HPV status, and the surgical diagnosis were not reviewed. The applications for this study include that it may or may not change patient management, which is frustrating. In the author's opinions, HSIL diagnosis is followed up with colposcopy and sampling, allowing for more accurate determination of endocervical gland involvement. However, by their own data, we can see that larger specimen types are more likely to be diagnosed with EGI. So, in my opinion, HSIL EGI could prompt larger surgical specimens. They also state that the utility is unclear. The majority of extensively sampled surgical resection specimens do demonstrate EGI, regardless of whether EGI was diagnosed on the Pap test specimen. And then again, the diagnostic criteria still remain elusive. All right, that's all for mine. Thank you.
Okay, thank you. That was a really good summary of that topic. And I knew when I picked the paper that it was complicated, and it's unfortunate that we, well, it was an elegant study, but also they sort of started off and then ended up at the same place. Like you said, there's not really consensus agreement, but still a really good study. And I think, as you emphasized on one of your beginning slides, it reinforces the importance of the differential diagnosis of like the hyperchromatic crowded group, and that you should think about this when you're seeing those groups. And you could see in their table, you highlighted it, table 2, that HSIL EGI on preceding PAP was significantly different in terms of identifying cases of adenocarcinoma. So certainly the overlap with AIS or adenocarcinoma is there, right? But they also sort of removed that uncertainty by only providing for the participants to pick either HSIL or HSIL EGI. They didn't allow for AIS, so that would probably make it easier in a study, but in the real world, you can't do that. So now we're going to have our polling questions for the audience. The first question was, which of the following is true regarding endocervical gland involvement as in pap smears as observed in this study? patients were more likely to have a preceding H-cell pap diagnosis. So that first answer is wrong. And 75% of the audience did pick the second answer, which is true, which is inter-observer concordance was poor for the assignment of EGI and Papanicolaou test specimens. I think Dr. McMurtry did a good job covering that, some of the challenges with that in terms of not having established criteria for making this diagnosis. Sometimes in inter-observer studies, people show the slides to a group and then do education and try to show a delta there, but it's hard to do that when there aren't well-established criteria. So patients with this diagnosis on PAP were not more likely to have endocervical gland involvement. That's not true. And then overall, this diagnosis on PAP had excellent sensitivity. Also, unfortunately, not true. So the second question is, which of the following is true regarding endocervical gland involvement on tissue sections? That first answer is true, that several studies have shown, even independent of margin status, it is associated with higher rates of recurrent disease, particularly following cryotherapy. This is an area that has some studies showing the other finding, but I think most pathologists that I know still report endocervical gland involvement on cervical specimens, both biopsies and resections and hysterectomies. And the other three are just distractor answers. Those are not true. And 88% of the audience chose that correct answer. So I think we're good there. And now we can move to the second presentation with Dr. Bhardwaj. You can go ahead and share your screen. Oh, hang on, I'm sorry. We do have a question for Valarie, you can turn your camera back on if you want. Swati, you're welcome to turn your camera on too if you want to help answer this question. So we do have a question. What are your thoughts about the study design with respect to the diagnosis of SMILE, which can be challenging to distinguish from H-cell EGI and surgical specimens, but is clinically important to do so? Could any of these cases have been SMILE instead of H-cell EGI? Are there good criteria to distinguish SMILE versus H-cell EGI in cytology samples? And you can take a stab at this, Dr. McMurtry. I know this is kind of next level, but you're going to be a cytofellow soon. So what do you think?
So as far as the first question, about whether there could have been SMILE on some of these surgical biopsies, and that is true. They did not review the surgical diagnosis. So we're dependent on what that first call was.
Right.
And as far as distinguishing SMILE from H-cell EGI on pap test specimens, I am not sure that's possible right now.
Yeah, I have to say, there is one paper which I will put online when I post the video about finding SMILE in pap smears, but to the best of my recollection, they did it the other way, right? They found SMILE on tissue section and then went backwards. So I think that that's a hard diagnosis to make because in my mind, SMILE is not, if I compare it to conventional AIS, it's not quite as atypical looking to me. So that to me is a really difficult diagnosis to make. Although I think we're lucky in the sense that SMILE tends to travel alongside H-cell a lot of the time, which is something that we're overall pretty good at finding in pap smear, right? So thank you for the question. That was from Dr. Rabin. That's a really good question. Okay, so now Dr. Bhardwaj, you can go ahead and share your screen and get started.
All right, so today I'll be discussing this article titled Morphologic and Immunocytochemical Features of High-Grade Serous Carcinoma of Ovary in Ascitic Fluid Effusion and Fine Needle Aspiration Cytology. It was published in the American Journal of Clinical Pathology in July 2020. And the study was conducted at the Postgraduate Institute of Medical Education and Research at Chandigarh in India. So the traditional method of treating high-grade serous carcinomas is that the patients undergo a primary debulking surgery followed by adjuvant chemotherapy with taxane-based or platinum-based drugs. Now, in some patients who cannot undergo primary debulking surgery, an alternative approach of giving neoadjuvant chemotherapy 3 to 4 cycles followed by interval debulking surgery is performed. Now, this alternative approach has been found to be as effective as the standard approach. At the same time, it has significantly lower adverse effects. So a lot of gynecologic oncologists are favoring this method of treatment, but that requires a preoperative definitive diagnosis of high-grade serous carcinomas. So the research question behind this study was whether or not we can render a definitive diagnosis of high-grade serous carcinoma on cytology alone. And so the authors had the aim to perform a detailed morphologic and immunocytochemical evaluation of smears and cell blocks in patients diagnosed with high-grade serous carcinomas by assessment of fluid cytology and FNA specimens and correlation with histopathological findings. So they did a retrospective analysis of all cases of high-grade serous carcinomas diagnosed from January 2015 to June 2018 at PGI-MER Chandigarh. And the clinical details, CA 125 levels and radiologic details of the cases were retrieved from medical records, following which a cytopathologic evaluation was performed, cell blocks were prepared, immunohistochemistry was done, and histopathological evaluation was done. So for cytopathological evaluation, the authors studied both ascitic fluid samples as well as FNA specimens of the adnexal mass. The ascitic fluid samples were routinely processed and 2 slides were prepared per case. So one was an air-dried smear that was prepared from the centrifuge deposit of the ascitic fluid. And the second one was a Pap stained LBC preparation. And all of these slides were evaluated by 2 pathologists independently for the following features. That is, what was the cellularity? And the cellularity was graded as 1+, 2+, or 3+. So if there were less than 10 tumor cells in 10 high power fields, it was graded as 1+, 11 to 100 tumor cells 2+, and greater than 100 tumor cells in 10 high power fields was graded as 3+. The authors also noted the tumor cell arrangement, whether or not they saw papillary clusters or abortive papillary clusters, or whether the cells were just singly scattered. They noted cellular features, presence of nuclear pleomorphism, and presence of other inflammatory cells. Following which cell blocks were prepared by the plasma clot thrombin method, and an IHC panel comprising of CK7, CK20, PAX8, WT1, P16, P53, plus CDX2, GATA3, and TTF1, if required, were performed. The histopathology evaluation was performed later on, and the specimens were grossed according to the CFIM protocol. The tumor type, grade, and probable site of tumor origin was determined. They also noted the chemotherapy response in these specimens that was graded as 1+, 2+, or 3+ on the basis of the response, whether it was no response or complete response. So coming to the results, they noted that the CA 125 levels reduced from 4.97 to 99.6% after chemotherapy and treatment, and there was a median of 97.8% reduction. They studied a total of 288 cases, out of which 175 underwent primary debulking surgery, that is the traditional approach to treatment, and 113 underwent interval debulking surgery after neoadjuvant chemotherapy. In these cases, a pre-neoadjuvant chemotherapy diagnosis was obtained in 99 cases. 93 of them were diagnosed by cytopathology alone. Out of these, 82 cases were diagnosed on ascitic fluid and 11 on FNA. So now the cytomorphological features that they found were that majority of the cases, that is 47 out of 93, had 2+ mere cellularity, followed by 1+ and 3+. Majority of the cases showed moderate to marked nuclear pleomorphism. And in 71 out of 93 cases, they found papillary clusters. Coming to immunocytochemistry, all of the 51 cases on which immuno was performed were positive for PAX8. Only out of these, 46 showed a strong PAX8 positivity. All of them were positive for WT1, but 45 showed a strong staining and 6 showed a weak staining. There were 3 patterns of P53 staining observed, that is mutant type, null type, or cytoplasmic type, which we'll see. So these are representative images showing the tumor cellularity. The first row shows 1+ cellularity, that is less than 10 tumor cells in 10 high power fields. The first figure is of an air-dried preparation stained with Giemsa. The second one is a Pap stain preparation, and the third one is a cell block stained with HNE. The second row shows 2+ cellularity of 10 to 100 tumor cells, and the third row shows greater than 100 tumor cells in 10 high power fields. These are representative images, figure A being from the air-dried smear stained with Giemsa, figure B, Pap stained LBC preparation, and C is the HNE stained cell block preparation. We can see the morphology, that there are papillary clusters present. The morphology is clearer in the LBC preparation because of the thinner preparation. And also the nuclear pleomorphism can be noted. These are representative images of the immunohistochemical stains. PAX8 staining was nuclear, diffuse, strong. CK7 was membranocytoplasmic, CK20 patchy, WT1 diffuse nuclear, and P53 showed variable staining patterns. So majority of the cases showed, that is 33 cases, showed a mutant type P53 staining pattern, that is a nuclear staining was seen. In one case, cytoplasmic staining pattern was observed. And in 17 cases, a null type of P53 staining pattern was observed. That means you can see the nuclei are not staining at all. In these null type P53 cases, a confirmatory P16 staining was also performed. So the authors also noted the chemotherapy response scores and tried to correlate it with morphologic parameters. So these are the 3 different rows showing chemotherapy response scores of 1, 2, and 3. That is no response, partial response, and complete response. So in this no response case, we can see the tumor was highly cellular even after chemotherapy. And here there is a significant reduction in tumor cellularity. In case 3, where there is a CRS 3, that is complete response to chemotherapy, we can barely see tumor cells, mostly just calcification. So in these CRS 3 score cases, it was even more important to have a pre-operative or before the interval debulking surgery to have a cytology or a tissue material on which the immunohistochemistry could have been performed, because there was no tumor tissue left after chemotherapy at all. The authors also noted whether or not there was any change in the immunohistochemical staining before and after chemotherapy. So in the first row, we can see this P53 mutant type staining before chemo, and it remained the same after chemotherapy. Similarly, the cases that showed a null type of P53 staining with positive P16 before chemotherapy with a yellow outline remain the same staining after chemotherapy. So on the right with the green outline, we can see the same case after chemotherapy showing a similar staining pattern of null type P53 and positive P16. So now coming to the discussion. Now, in order to establish a diagnosis on ascitic fluid specimens, the first question that arises is whether or not we are dealing with a malignancy. So we first need to establish a morphological diagnosis of malignancy. After the authors did that, the next question was whether it was an adenocarcinoma or mesothelioma. In some cases, this was the question that was answered by performing immunohistochemistry with CEA, B72.3, and calretimin. Now, once they confirmed that they are dealing with an adenocarcinoma, the next question was the origin of the carcinoma. So for that, they did a panel of immunostains, CDX2 to rule out colorectal origin, TTF1 to rule out lung origin, GATA3 for breast and urothelial origin, and GCDFP for breast origin specifically, and PAX8 to confirm a Müllerian origin. After which WT1 and P53 was performed for confirmation of the serous type of carcinoma. Only if P53 was found to be the null type, a P16 staining was also performed. The advantages of neoadjuvant chemotherapy are that there is reduced surgery-associated morbidity. At the same time, it is effective in reducing disease burden. So this is why it is gaining popularity among gynecologic oncologists, and which is why we need to have a preoperative definitive diagnosis. The author studied and reported morphological and immunohistochemical features, which were similar to those reported by previous studies by Zheng et al., Wang and Zhao et al. In 100% of their cases, they found PAX8 positivity, which is a reaffirmation of previous studies. Regarding WT1 positivity, they did note that it can be seen in mesothelial cells as well. So they resolved this question on the basis of morphology. So morphological features like presence of microvilli or tumor cell or windows in between the cells, or intensity of immunohistochemical staining. So they found that WT1 staining was much more strong and intense in tumor cells as compared to the weak staining observed in mesothelial cells, and by parallel comparison of these cells with PAX8 stains. So if there's a cluster that is staining both with PAX8 and WT1, then it is a tumor cell cluster, not a mesothelial cell cluster. And regarding the P53 positivity, they found 68% of their cases showed a mutant type staining, that is diffuse nuclear, while this percentage has ranged from 71 to 98% in previous studies. They also found one case of cytoplasmic type staining, which has been previously reported. Now, this happens when there is a loss of function mutation that results in the loss of the nuclear domain of the protein, because of which it comes out of the nucleus and stains the cytoplasm instead. they tried to see if there was an association between any morphologic or IHC parameter that could predict how the tumor is going to respond to chemotherapy, but they did not find any association between any morphologic or immunohistochemical parameter or the CRS score. So coming to the analysis of the study, I feel the strength of the study is its sample size. They studied 288 cases of high-grade serous carcinomas, and they did a very thorough evaluation and workup of all the cases with description of findings in fluid cytology, FNA smears, cell block, as well as final excision. And they also correlated the pre-chemotherapy and post-chemotherapy immunohistochemistry as well as morphology findings. Now, coming to the limitations, I believe that one of the major limitations of cytology in general is that we may not have enough material to perform all the immunostains that we do want to perform. So I feel it was not addressed whether there was any positive material in any of their cases. Were all of the specimens that they had adequate for all the immunostains that they wanted to perform? And I would have also wanted to know how many immunostains were performed in different specimens. They said they were variably done, but I would have wanted to know which case required how many immunostains, and whether or not they needed any repeat FNA or repeat cytology specimens to get sufficient material. Overall, I feel it's an excellent study and has important clinical application. So if we can, the study establishes important morphologic and immunohistochemical features required for preoperative cytologic diagnosis. And if we can make a preoperative cytologic diagnosis, we enable a less morbid surgery and a less morbid treatment for the patient. Thank you.
Thank you, Dr. Bhardwaj. That was really excellent. We'll go ahead and do the poll for the second article. There are 2 questions there. I'll also bring those up on the screen for those watching this online. Okay, go ahead and end the poll and I will share the results with everyone. So for those online, you can see the highlighted answers. The first question is, what is the current standard treatment of advanced stage high-grade serous carcinoma of the ovary? And the answer is primary debulking surgery followed by adjuvant chemotherapy. This new approach, this neoadjuvant chemotherapy followed by interval debulking surgery is not the current standard of treatment, I guess I should have said, in the United States. And also with the caveat that if you look at the NCCN guidelines, there are times when it is the standard of care in more advanced cases. So, but this question was taken directly from the discussion of the paper. But I think what they're getting at is that the, standard of care since a long time has been primary debulking surgery followed by adjuvant chemo, and that this paper is addressing a problem that's coming up now about diagnosing patients who are receiving neoadjuvant. So I hope that wasn't too confusing. It looks like it was split pretty evenly between the 2 first options. So just a little clarification there. And then the second question is, in which of the following scenarios did the authors perform a P16 stain? And the answer is null type P53. The other patterns, cytoplasmic and mutant, would have been diagnosable. A lot of people use P16 immunohistochemical staining for null type P53 neoplasms, not just in the ovary, but sometimes in the endometrium, also maybe in the fallopian tube. Some people are not as comfortable interpreting a negative immunohistochemical stain, just with all the other things that can go wrong with immunos. So that is the scenario in which they used that. And I see that we do have another question. Could the molecular subtypes or set variants of high-grade serous carcinoma be suggested based on the study? What do you think, Dr. Bhardwaj?
I think in this study, they have not addressed the set type of molecular subtype, but I have read the cytologic features. So you're supposed to have greater than 3 times, there has to be a high degree of nuclear pleomorphism. And I think there is a greater than 3 times variation. So there are criteria, but that has not been addressed in this particular study. And I don't know whether or not we can, I'm sorry.
No, I agree. Go ahead. Yeah, I don't know whether we can either.
Yeah.
I think probably getting to a definitive diagnosis of a set type carcinoma on a cytology specimen would be pretty tough. Although there are some institutions that are doing more of kind of a look and see operation with biopsies, maybe you would have a chance at doing it, but I would think you would need some architecture. I would think on something like ascites, that would be a really difficult diagnosis. And then another question that I had was, or just a point that I think that this article, and the reason I picked it, was that cytology is evolving as, I think, a form of surgical pathology, of diagnostic surgical pathology on really small specimens, right? I mean, there are whole areas of literature about this now. In the lung, they've been doing it for a long time, but I think GYN is sort of coming into that now. Pelvic washings used to be very common, then they weren't so common, and now things like ascites are coming back into play, right? So at your institution, are you, I mean, you're only in your first year of residency, but you did do a residency before this. So have you been diagnosing high-grade serous carcinoma of the ovary on cytology? Is that something that you all were doing?
So I don't have experience here at Icahn School of Medicine, but back in India, I was in Safdarjung Hospital, and we did that a lot. So in fact, I did a study on immunocytochemistry in like overall, not just GYN, and we had a large percentage of those cases were actually ascitic fluid specimens, and quite a lot of them were high-grade serous carcinomas, where we did give a diagnosis beforehand, and we did immunohistochemistry. In fact, we did immunocytochemistry as well on the centrifuge deposits directly after fixing it in cold acetone.
Oh, nice. Like a direct smear. That's so fun. We sometimes would do that on thyroid aspirates, but it always scared me just a little bit. Yeah, it's really interesting because the presentation with ascites and carcinomatosis does lead one, especially in, a female patient, to a diagnosis of a Mullerian carcinoma, but there are other things. So it's so important, you were saying, the role of immunohistochemistry just to confirm that diagnosis, especially if the patients are going to be receiving chemotherapy. And then, yeah, so that was a really good summary, Dr. Bhardwaj. And now you can stop your camera if you'd like. And then Dr. Njenga, you're up.
Okay, so welcome to the third journal article. I will be presenting the paper that is projected on your screens right now with a little bit of an African take to it. So to begin, now cervical cancer, as we know it, is a main global health concern, ranking fourth amongst the most commonly diagnosed malignancies worldwide. And if I take Kenya specifically, it is the leading cause of cancer-related deaths, with 3,286 deaths recorded per annum. And it is the second most common cancer amongst females, second to breast cancer. And the question listening to those figures becomes why, right? Yet it was discovered that uterine cervical cancer could be diagnosed via vaginal smear nearly a century ago. Now, as regards the screening program here, we have attempted to implement pap smear-based programs, but to no avail. And this has been due to a lack of resources in terms of funds and knowledge, in that there are very few qualified medical personnel. And so what we have currently resorted to is what is termed as VIA-VILI, visual inspection with acetic acid, visual inspection with Lugol's iodine, which is not only cheaper to perform, but has been shown to have similar sensitivity to the conventional PAP, which is what is currently practiced in Kenya. That said, however, in the Western world, cytology screening has had tremendous success in the prevention of cervical cancer, but further advancement has largely been limited by its relatively low sensitivity to high-grade lesions, and this is especially so on the conventional PAP. And so enter high-risk HPV testing, which in conjunction has significantly increased sensitivity for detecting high-grade lesions. Hooray for the patient? Yes, certainly. But the question now becomes, can high-risk HPV testing alone be effective and sufficient as a primary screening method for cervical cancer? Now, projected here are two studies with conflicting data. The first is a study that was published by Austin et al. And they found that liquid-based cytology identified more women who were subsequently diagnosed with cervical cancer and HISIL in comparison to high-risk HPV testing, right? But then below that, we see the Kaiser data, which demonstrated that high-risk HPV testing alone identified more women who were subsequently diagnosed with cancer and precancerous lesions compared with the Pap test alone. And so the Kaiser data concluded that the added benefit of co-testing only applied to a small subset of women. So we still haven't answered our question, right? Which is it? Can we or can't we? And so this study was performed to analyze the efficacy of co-testing in the prediction of 3-year cumulative risk of biopsy-confirmed high-grade cervical lesions amongst different age groups. Now, to go through the study design in brief, from a data pool of over 600,000 Pap tests recorded from 2013 to 2018, the authors were able to assemble a cohort of 9,434 patients who had undergone high-risk HPV co-testing and follow-up biopsies. These biopsy results were then recorded and categorized into 3 groups, that is benign, your low-grade lesions, which encompass CIN1 and HPV effects, and then high-grade cervical lesions, which encompassed HISIL, CIN2 and CIN3, as well as AIS and invasive cervical carcinomas. These cases were then grouped using age stratification. And then finally, the 3-year cumulative risk of developing cervical cancer and high-grade dysplasia was analyzed and compared between the groups. Now, briefly on the statistical analysis. Now, for the 3-year cumulative risk of developing biopsy-confirmed lesions greater than or equal to HISIL for each co-testing results group was calculated, and then these groups were stratified by age. Then a chi-square was used to compare baseline co-testing results of high-risk HPV positive, Pap negative, Pap positive, sorry, high-risk HPV positive, Pap negative, and then high-risk HPV negative, Pap positive. A Fisher exact test was used to compare age groups. Royston p-value for trend was used to assess the trend test, and all the analysis were performed using Stata. And so now we move on to the results. So let's begin by understanding their baseline results. So this column on the far left shows the liquid-based Pap results, right? Then we have the total number of cases that were HPV positive. And of those that were positive, the total number that were positive for HPV 16 and 18 versus those that were non-HPV 16 and 18 positive. And then finally, the cases that were negative for high-risk HPV. Now, 86% of the cohort cases tested positive for high-risk HPV, with a total of 8,116 cases. That is what is highlighted in red here, whereas only 14% were negative, with a total of 1,318 cases recorded. Now, in concordance with the results of recent studies, the current study demonstrated that women with co-testing results of HPV positive, Pap positive, had the highest 3-year cumulative risk of development of high-grade cervical lesions at nearly 20%. There was a moderate risk in those who were HPV positive, Pap negative at around 8%. And then a much lower risk in those who are HPV negative, Pap positive at less than 5%. Now, when they excluded cases with CIN2 lesions, then the 3-year cumulative risk of developing greater than or equal to CIN3 showed the highest risk again in those who are HPV positive, Pap positive at 11%, with the lowest risk seen in patients who are HPV negative, Pap positive at 1.7%. Both had a p-trend of less than 0.01. Now, the overall 3-year cumulative risk of developing HISIL or greater trended lower with an increase in age, as we can see here. And this was especially so in women who were greater than 50 years of age. Now, patients who are HPV positive, PAP positive, let's look at the orange line here, or HPV positive, PAP negative, that is the blue line, had a 3-year cumulative risk of HISIL or greater that peaked between the ages of 30 to 39 years. And this was noted to decrease significantly at ages 50 to 59, at ages 50 to 59, I'm sorry. And what about the women who are aged less than 30? Now, yes, Bethesda does reserve co-testing for women aged between 30 to 65. But it is worth mentioning that the authors noted that in their practice, co-testing was increasingly being performed in women aged less than 30. And so this provided them with the opportunity to observe the efficacy of co-testing in a younger population. So these women had an overall 3-year risk of developing greater than or equal to HISIL that was similar to women aged between 30 to 39 years. Now, HPV negative, PAP positive overall showed a much lower risk of developing greater than or equal to HISIL. That is the green line here. And this was especially so among women aged greater than 40. And this was attributed to increased false positive rates in postmenopausal women due to several factors such as atrophy, reactive atypia, lower cellularity, etc. Now, the positive rate of baseline testing was significantly higher in women who had HISIL or greater, right, in comparison with those who had low SIL or benign findings on biopsy follow-up. The positive rates again trended lower after 40 years in women with benign or low-grade lesions. However, they did remain significantly higher in females with biopsy confirmed greater than or equal to HISIL. And so that would suggest that the specificity of HPV testing steadily improved with an increase in age. The significantly different risk profiles observed between the different co-testing groups offered valuable information for risk stratification, which has an impact in cost-effective management by basically identifying individuals who will benefit the most from treatment. And so we go back to our initial question. Can high-risk HPV testing alone be effective and sufficient as a primary screening method for cervical cancer? Well, this study found that both tests showed considerable false negative results in detection of high-grade cervical lesions when used alone. And the histology follow-up data demonstrated that neither a negative high-risk HPV test result nor a negative PAP result alone brought the 3-year cumulative risk for high-grade cervical lesions down to a considerably safe level. And so the authors concluded that co-testing remains the most effective screening strategy for cervical cancer prevention at current. And so is it applicable? Yes or no? Now, you can only affect something by being on location, understanding the location, and then using the means available. Like I mentioned at the beginning of this presentation, low and middle income countries in sub-Saharan Africa have failed to achieve significant decreases in the cervical cancer burden. And this has been due to implementation barriers of pap smear-based programs. So is it applicable? Is co-testing applicable? Not currently. But primary high-risk HPV testing, I'm going to say yes to that, right? Because whereas yes, a negative rate does not bring down the risk of development of HISIL or greater to a considerably lower level, then with recent findings of the use of GenExpert for screening for high-risk HPV, it may just end up being cheaper than the pap smear and have a more considerable health impact in an area where we are currently underperforming.
Thank you. You can go ahead and stop sharing your screen. We'll do your polling questions, and I would invite folks to throw your questions into the Q&A section. And also I will give a quick plug for the evaluation, which will launch when you leave the meeting. Don't leave yet, but if you have to run, it'll pop up in your screen, and that really helps ISGyP Live know what everyone's thinking and what you want from us in the future. So I have launched the polling questions, and they are also up on the screen for those watching on the video. Share the results with everyone, and then for those watching on the video, you can see the highlighted answers. So which of the following is true regarding high-risk HPV testing and pap smears? It has been incorporated into cervical cancer screening and management algorithms as a co-test with cytology to maximize the detection of high-grade cervical lesions in women greater than or equal to 30 years of age, or to triage cases with equivocal cytology. So that is a true statement. And then the last one, which of the following is true regarding the findings of this study? High-risk HPV PAP co-testing is an effective tool for cervical cancer risk stratification in women with the highest 3-year cumulative risk of greater than or equal to HSIL noted in women with positive HPV and PAP co-testing results. So I think this brings up a lot of interesting questions. I don't see any questions in the QA, but I have some. So I don't know if our panelists want to turn their cameras back on, Dr. Njenga especially. I would like to hear your perspective on some of these questions about the implementation of co-testing, and specifically WHO just yesterday had a launch of a global strategy to accelerate the elimination of cervical cancer. And this is a screenshot of the web page, which I will put in the web page where I post the video of Journal Club. But they have a goal now to eliminate cervical cancer, just like they eliminated polio by the year 2030. All countries can achieve, they say, 90% vaccination coverage, 70% screening coverage, and 90% access to treatment for cervical precancer and cancer, including access to palliative care. And then this is a patient here who's narrating her experience. And I encourage people to watch the video. It's very powerful. They interview patients from all over the world to talk about their experience of having cervical cancer. And I thought this was an interesting article. This was linked to on the WHO website, but they talk about, and Dr. Njenga touched on this, the fact that in the States, we talk about pap smears and co-testing, but this is not the experience of everyone in the world, because pap testing is expensive to perform, not only in terms of testing, but also in terms of personnel who can read those tests. And this is mathematical projection out to the year 2120, and it shows how you could reduce the mortality related to cervical cancer using different implementations. And the ones that have the sharpest decline, say by the year 2040, it's gone down quite a bit, is when you not only do vaccination, but you also have to do lifetime or screening. And in this study, they're just talking about 2 times in a patient's life, at age 25 and at age 35. So I just wanted to bring this up because I think in the States and maybe some more resource-rich countries, we can just learn more about the experience of folks around the world. So did you want to comment on anything else, Dr. Njenga, or were you finished with your comments on that subject? She's turned her camera on.
Thank you, Natalie. Yes, I was done with the comments.
Oh, lovely. Okay. And then I don't see that we have any other comments on this article. I just thought it was nice this month to have 3 very different kinds of articles, and these articles where folks grab, 9,000 pap smears. It really is necessary to have a cohort that big to really identify trends. And I do think it's interesting because I remember that HPV co-testing was something that was just starting to happen when I was a resident back in 2008. It was just being brought online, and people were really afraid that the pap smear was going to go away. It wasn't going to be important anymore. But it still seems like this article says, that like Dr. Njenga emphasized, there's significant false negatives with both tests, and it really does seem best, even in 2020, to keep doing both of them at the same time so that we don't miss these patients, especially since it is relatively non-invasive to keep screening for a disease that does have such a high mortality rate. So thank you everyone for coming, and thank you for your participation. All 3 of our panelists, if you want to turn your camera on and just say Goodbye to everyone. And then next month, the theme is ovarian neoplasms of the non-serous variety. So if there's anyone, oh, she's got a mask on. Yay, 2020. Goodbye, everyone. And if you want to present, or if you have a trainee who would like to present, please get in touch with me. And I really thank you all for coming. Have a great day. Stay safe out there, everyone. Bye.
Thank you. Bye.
Mhm.